Afternoon, everyone. My name is Joseph Chebe. I'll be your host for our webinar today. I want to welcome you all to our webinar, to all our referral partners, our insurance partners, and our interested patients. Karibuni sana. Our topic for the day will be global solutions for stomach and digestive cancers, early detection, advanced treatments, and seamless care. So I am hoping that we will have an amazing session. I'm really looking forward to it. We have amazing international experts who will take us through the session and the topic for the day. I'm also joined by my colleague who will help me in running the session. And just to give a little bit of a rundown of what will happen, we'll just have a brief overview of what My One Health does and how we help patients access healthcare abroad. We'll have our two speakers take us through the session and present to us what they have prepared. And then finally, we'll have our interactive Q&A session. And then we will have our next steps for all our insurance, referral partners, and for our online patients. So just in case you have any questions throughout the entirety of the event or the webinar, you can just go to, on your screen, the bottom right side, there's a little box with a question mark. Underneath there's some slight words Q&A. So you can just pop in there and have your questions written in, and then our experts will answer in any questions you may have through the webinar. Yeah, and I guess that's more or less like it. So probably, I guess we can kick off. It's 2:05 East African time, and I guess it's a good time for us to officially kick off. So right now, I want to invite my colleague, Eva, to give us a brief introduction about what My One Health does. Karibu, Eva.
Thank you, Joseph, and warm welcome to everyone joining us. I hope you're all doing well. So as Chebe or Joseph mentioned, my name is Eva Mutuku. I'm the product manager for My One Health, and I'll just give you a brief description of who we are. So as My One Health, we are a medical facilitation company, and we assist patients globally to access specialized healthcare wherever they want to go. So for example, for those who are here in Kenya or whichever country you may be in, we assist you to go abroad to get specialized healthcare, and we kind of bridge that gap between the patients and the facilities across the world. So as My One Health, we have partnered with around 150 hospitals around the whole world. And we also have more than 15,000 doctors and specialists around the world as well. And so far, we have assisted more than 50,000 patients to access medical healthcare across our partners in the world. Now, for today's session, we all know that in the world today, stomach cancer and gastric digestive cancers are one of the cancers that have really risen in the past few years. And it's important for us as patients to just get to know what are some of the things that we need to understand, because we find that for cancer care, it's a disease that many of us come to know about it way too late. So as patients, it's good for us to know what are the things that we need to look out for, what are the things that we need to prepare for this, and how can we also get treatment for the same. So we are joined by doctors from Apollo Proton Cancer Center, which is India's first proton cancer hospital in the world. And we are happy to have them. They are some of the best in the whole world. So I'm looking forward to this session. And in case you have any questions, as Chebe has mentioned, please let us know in the comment section. Thank you, and looking forward to this session.
Okay, thank you so much, Eva. So I'll go ahead and introduce our experts for the day. We have amazing experts from Apollo Proton Cancer Center. we are honored to be joined by Dr. Venkatesh Munikrishnan, Senior Consultant, Colorectal and Robotic Surgeon at Apollo Hospitals, Chennai, and the founder of Chennai Colorectal Clinic. With over 2 decades of surgical experience in international training from the UK and Germany, he is widely recognized as one of India's foremost experts in gastrointestinal and colorectal surgery. His expertise is especially valuable in surgical management of complex gastric and stomach cancers. Dr. Munikrishnan's commitment to innovation and patient-centered outcomes continues to shape the future of cancer surgery in India. With him, he's also joined by Dr. Bala Murugan Srinivasan, right? Yeah, he's also a senior consultant of radiation oncologist at a Proton Cancer Center, Chennai, with over 15 years of experience in treating gastrointestinal cancers. His expertise lies in managing hard-to-treat cancers, such as those of the stomach, and he's a key member of Apollo's multidisciplinary oncology team. So we have these two amazing experts, and I'm sure they'll have a wonderful session in taking us through gastrointestinal and stomach cancers. So Dr. Venkatesh, kindly give us a brief introduction of who you are, your expertise, and maybe even something personal about your life, and then we can continue on with what you have for us for the day.
Okay. Hello, everyone. Thanks for the invitation to speak. So today we're going to be talking about GI cancers. So with me is my colleague, Dr. Bala Murugan, who's an upper GI surgeon. He will be following me. I'm Dr. Venkatesh Munikrishnan. I had the colorectal surgery services at Apollo Hospitals in Chennai. I lead the team for GI cancers with my colleagues. I subspecialize in colorectal surgery. I'm from Chennai, but I did all my training in the UK, where I got my MRCS, FRCS, and CCT in colorectal surgery. Since returning to India about 15 years ago, and then setting up the colorectal services at Apollo, we've built on those experiences and built one of the most cost-efficient colorectal surgery programs in the world. So what I'll be sharing today is a little insight into what's happening in colorectal cancer in sub-Saharan Africa, and also what we are doing to address or what to these challenges, and how we developed the colorectal surgery program with advanced technology, which is cost efficient to be delivered anywhere in the world. Okay, so I'm trying to share my screen. Let's see if I can do that. One sec.
Probably as you share your screen, maybe Dr. Bala can briefly introduce himself, and then Dr. Venkatesh, you can go on and share your screen.
Bala?
Yeah, am I audible?
Yes, go ahead.
But I couldn't see my screen.
Yeah, I think your screen, you're on, your camera is on mute, I think.
Go ahead. Okay. I couldn't see my screen. So you can go ahead with your presentation. I'll just check here.
Okay. Can you see my screen now?
Yeah, I'm able to see yours.
Okay. What about Cheve? You're able to see it?
Yes, I can see your screen.
Okay, so we're going to start off with what we're seeing with colorectal cancer in Kenya, roughly what's happening, and some insights into what are the common symptoms, and then how it is managed, and then we'll go into give you an insight of what is happening in our program in India. So if you look at the global trends of colorectal cancer, in 2022, there are 1.9 million new cases around the world. 93 9 lakh, almost 1 million deaths projected to increase by 73% by 2040 in number of new cases. In Kenya itself, or in sub-Saharan Africa, you would see 8 per 100,000, and in India, we see about 4 per 100,000. And the survival rates are low in sub-Saharan Africa due to late presentation, very similar to what we see in India, because we don't have a screening program, because one of the reasons is that we have a lower incidence and lack of awareness, and patients present at a late stage. So number of deaths from colorectal cancer are, in sub-Saharan Africa is about 14,227 deaths per year, and that's a lot. Similar numbers are seen in India too. Eastern Africa mortality rates from colorectal cancer are almost 40%. Every 2 out of 5 patients die from the disease, and it's primarily due to late presentation. If you look at what are the commonest symptoms, patients who present with colorectal cancer are rectal bleeding, change in bowel habit, which could be constipation or diarrhea, weight loss, or anemia, which has been persistent for about more than 6 weeks. Now, if you have any of these symptoms, as I said, for more than 6 weeks, patients should go see their doctor and should have a rectal examination and further assessment, probably with a colonoscopy, which is a gold standard. Now, if you look at the risk factors, particularly in relation to in Africa, age more than 70, twice likely to die from the disease. Married patients are 2.5 times higher risk to die. That's it's an interesting statistic, though. CEA levels 5+ had twice higher risk to die from the disease. Now, CEA is a blood marker for colorectal cancer. If you had comorbidities, 84% higher risk to die from the disease, and stage 4 has 8-fold higher risk compared to stage 1. So if you look at the colorectal cancer survival in sub-Saharan Africa compared to the worldwide data, we see that in Kenya, first year survival is 74%, but that drops down to 43.5% in 5 years' time. Now, similar trends are seen in Iran, but at a slightly higher, better survival rates. And in Western Europe, you'd expect at least 20% better survival rate compared to Africa. Now, variation survival colorectal cancer in sub-Saharan Africa are due to the stage of diagnosis, treatment options, availability of screening programs, access to technology such as robotic surgery, and access to subspecialist colorectal cancer clinicians, which were part of a bigger multidisciplinary team, which includes medical oncology, radiation, and colorectal surgeons. Now, what are the challenges of managing colorectal cancer in Kenya? Limited access to treatment options such as chemoradiotherapy and advanced subspecialist surgery, delay in diagnosis, late presentation, cultural beliefs, and financial constraints. So in India, we've had very similar challenges. We are a big country. We have more than 1.4 billion population. We don't have a screening program. A lot of our patients, at least half of our patients, pay from their pockets. It's a large country with very different challenges, but also very cost conscious. So we had to work on how do we set up a program which is accessible to everybody across the world, and also particularly local patients. So I'm going to give you what we've done in setting up a sustainable robotic colorectal surgery program. Now, surgical robotics, has evolved in the last 20 years. The market leader in this space is the Intuitive Robotics platform. It's taken about 20 years for them to evolve. Today, we are in the 5th generation, although in our hospital, we have the 4th generation. Pretty good technology, which delivers fabulously. It is essentially a master and slave concept. Essentially, if you go back, you can see that
recording in progress.
The console where the surgeon is sat and the robot is docked into the patient, and the robot surgery is delivered. So essentially, what you have to remember is this surgery is not done independently by the robot, essentially done by the surgeon, and every surgical move is replicated in a miniature fashion inside the patient. Now, what are the benefits of robotic surgery? For the patient, it is more precise, there's less pain, fewer surgical complications, reduced need for hospital stay, and a shorter recovery time. And for the surgeons, we have an enhanced visual field, 10 times magnification, three-dimensional views, superior dexterity. These are articulated instruments which are about a centimeter in size, which can get deep into difficult access areas like the pelvis where rectal cancers are, and we can do very fine surgery. Now, this is looking at the trends, what is happening around the world. Generally, there is a decline in open and laparoscopic surgery with an increase in adoption of robotics. A lot of the surgeons, trainees are asking for robotic fellowships because they see the future in robotic surgery, and that robotic surgery will become mainstream. And I think that's what's happening in the Western world and also in most of Asia too. Globally, there has been an increased adoption for robotics for different procedures across. Urology has always been in the forefront of adopting robotics because robotics was initially devised for prostate surgeries, but now multiple specialties adopting, including urology, gynecology, colorectal, general surgery, thoracics, and transoral. There is a huge uptick in the uptake of robotics for general surgery, which is one of the most fastest growing robotic programs in the world. So if you look at in India, there is a 46% growth over the previous year of adoption of robotics. And again, all specialties are growing. There we have more than 150 Da Vinci installations, and plus we have Hugo Medtronics, CMR Robotics, and also an indigenously made robot, which is the SSI Mantra, which is again very cost-efficient robot. So if you look at where we're using the robotics for surgery, for cancer care, primarily for cancer care, 70% of surgeries are targeted towards cancer care. 80% of this is done in Tier 1 cities, so the big cities. So given that this technology is expensive, but again, we are a very large population, primarily middle class, who wants to access good healthcare. So to help that, how, those are big challenges. One, we have to, use this advanced technology to benefit a majority of patients, and that's when it becomes a good program. Any technology is useful. If there is a good technology which is not accessible to everyone, then only to a small group of people who have the funding, then we are not really achieving our healthcare goals. So given those challenges, compared to laparoscopy, the use of robotics adds almost a $3,000 to $4,000 additional cost to laparoscopy. Then the challenge was, how do we adopt this technology, make it cost efficient? So we had to find ways to make operations super efficient so that this added cost is offset. So that pretty much our aim was to bring our laparoscopy and robotic costs for colorectal cancer to the same level. So how did we achieve this? So the most important things to think about is that we need to be subspecialized. As I said earlier, I went to England to train in colorectal surgery. I spent 15 years there. And so pretty much at the end of my training of 15 years, the only operations I was doing was in colorectal surgery. Colorectal cancer was the main part of it, with a lot of proctology, and benign colorectal work, which is, hemorrhoids, piles, fistulas, but a lot of work and training had gone into colorectal surgery. Now, if you subspecialize, now it's a big challenge around the world, particularly in countries like India, and also see that in Africa, is because surgeons don't want to give away their skill sets in other areas, like in upper GI or hernia surgery or general surgery. But again, you have to remember, if you do a particular operation more number of times, you become an expert at it, and also your outcomes will be better, which is the most important thing. We are here to achieve our outcomes. Of course, financial compensation is important, but the basic tenet in which healthcare evolves around, where even as a business, even as everything put together, the important thing is good outcomes for our patients. And if we can keep that at the center and still achieve all the other targets of high volumes, good revenue, acceptable margins for the healthcare services, then we are on a win-win, program. So subspecialization will give you high volume of patients in a particular area. So you and, for example, me and my team can do a lot of these operations again and again in our own field. For example, in the last year, our team did about close to 150 colorectal cancer resections, out of which 125 were robotic resections. So the more number of times we do it, we get really good at it, and our outpatient outcomes are great. Now, then we address the cost. How do we address the cost? Because we are adding this advanced technology, and it is going to cost us to give that. Now, as I said, that's where the subspecialization and the efficiency all come in together. Because you get really good at one particular operation, you're able to standardize that operation. For example, rectal cancer, and I'll show you how we've done that. We standardize the operation, we standardize our steps in theater so that every step is programmed, or if you know step 1, 2, 3, 4, it happens again and again, and it's the same operation again and again and again, and so we get really good at it. And then poor workflow also is a challenge, and we address that by increasing the theater efficiency. We start first as the first case in the morning. Every theater member is briefed of what their roles are, and we have all the equipment ready. All that is all, practiced so that we don't waste time when the procedure starts. We want the operation done, safely, quickly, and within the best time frame with the best outcomes. So if we put subspecialization, standardizing the operation, and the improving theater efficiency, you will be able to build a very sustainable robotic program. Now, as we looked at the previous slide, apart from that, how do you build an entire ecosystem? Because at the end of the day, we need to build a program. We need to build a bench strength of your surgical team, nursing staff. We need to teach and train them. We need to have a multidisciplinary team where you have your oncologists, surgeons, radiation oncologists, medical oncologists, radiologists, all of them are all aligned, who every patient goes through the tumor board and the MDT team. We make the decision, and then we give the best advice of the treatment plan for the patient. So then I've told you about teaching and training our teams, and then creating awareness and education to the community. Because once we do that, then they'll be aware of all the symptoms. They'll know when to ask for help, when to get screened, and also importantly, if there's a colorectal or a robotic colorectal program, they'll be able to ask for or demand these special programs where they can get good care with great outcomes. So if you look at our robotic colorectal surgery volumes, which was started in 2015, roughly we do more than 100 cases robotically a year. Of course, we do some more open surgery for more advanced cases which are locally, which can't be done through keyhole surgery, but routinely robotics is our approach. During the COVID years, the number of operations had a dip, but again, it's picked up, and we are touching more than 110 to 125 procedures per year in recent times. Now, our own experience that we've done 785 robotic colorectal procedures using both the Da Vinci and the Hugo platforms. If you look at our program case volume, if you see that majority of the colorectal work is done by subspecialist colorectal surgeons compared to general oncology or general surgeons who do everything who deal with all organs. So you will see that once you offer a service in subspecialized service, a lot of these patients will start to flow through your subspecialist, because everybody wants the best teams who have a high experience in this area to be operating on them. And so if you look at our case mix, most of our work is to do with rectal cancer, and the other resections are also a part of it. So we call these are frugal innovations. When you start a program, you need to keep the costs down. Now, these are general guidelines so that we can develop these programs even in Africa, because I know that we don't have programs as robust programs there. So once you set up a program, you have to start early. You have to build a two-team approach where there is a console team and a bedside team. The console team has a look at the reports. There could be a trainee with the console surgeon. The bedside team gets supports and sets the patient up and docks the robot in. We try to use the bare number of instruments which are required, robotic instruments, because each instrument costs. So our aim is to keep the number of instruments low, but achieve good outcomes. And we standardize the procedure. As experience build, the workflow improves and outcomes are achieved, and you become really efficient. Then you can add additional instruments and devices. And because you get so fast and quick, the additional instrument costs will get offset. So looking at the operation itself, what we've done is, for example, rectal cancer, we split the operation into different parts. So every time the same operation is done the same way. And even in the more important part of the rectal resection, again, it is split into several parts so that the entire team knows that you got to go step by step. Okay. Now I'm going to give you look at a few videos. This is a rectal cancer resection, and you can see this is how we start the dissection. You see these are articulated instruments. The camera control is with the surgeon. The left arm is a robotic arm holding the tissues. You see what clear the pictures are. We are able to see it in 3-dimensionally when you're in theater. You can see with the articulated instruments, you use the instruments as a paintbrush. So the dissection is very sharp, clear, very stable views. And you can see all the structures are very clearly demonstrated there. So you can see the big difference between laparoscopic instruments, robotic instruments is the articulated instruments. You can see there are 7 degrees of movement in these instruments, and you can see how they are, helping you retract and do a fine dissection. So next is a further dissection into the pelvis. One is on the left side is after radiotherapy, we're doing a rectal dissection, standard radiotherapy. The right one is where we give proton therapy for rectal cancer, and we see less tissue edema, and you can see it is a very sharp dissection. I'm going to play both the videos for you just to give an idea how robotic surgery looks like. It's very stable. It's fast. It's very controlled. It's bloodless field because of the subspecialized surgical surgeons we have in our team. You can see the instruments are articulated, and it can, we're using the instruments like a paintbrush. It's very sharp, precise, clean, and so that the patient's important nerves and tissues are preserved, and the tumor which needs to be removed is being excised carefully. You can see the white things which are over there. These are important nerves which control sexual function, urinary continence, and fecal continence. Now, if we can't damage those, that's why experience matters, the technology matters, 3-dimensional matters, and we're able to achieve that with this technology. And you can see the clarity with which we can see the tissues and how well we can operate. Okay, so I'm just moving to the next video again. So this is deep in the pelvis. This is getting really, really low. This is when the rectal cancer is very close to the anal canal. In 20, 30 years ago, when with these low tumors, the patients received a permanent colostomy, the whole anus was removed. Now we are able to remove these tumors, which are very close, low in the rectum and very close to the anus. And we're able to still do a fine dissection using advanced robotic technology and dissect them out and reconstruct them so that we can avoid a permanent colostomy. You can see, again, with what finesse we are able to dissect these tumors. We have one of the biggest volumes in robotic colorectal surgery in India with excellent outcomes, and I should be sharing some of those outcomes. I'm just going to, for want of time, forward these things. This is deep in the pelvis. This is the pelvic floor muscles. You can see with laparoscopy, open surgery, it's very difficult to see so low down. This is, this is basically looking inside the butt through the abdomen. Okay. Even in laparoscopy, it could be a struggle because you have straight camera and straight instruments. Because a camera, it can be flipped 30 up and 30 down very easily. We can do these complex maneuvers very safely with great visualization. If you see things great, you won't damage tissues, and that gives better outcomes for our patients. And you can see this is low in the pelvis. You're able to dissect beautifully deep down in the pelvis and remove these tumors, even if they're very close to the anal sphincters, that way avoiding a permanent colostomy. So we also use staplers. I'm going to show you. Now, this technology uses advanced AI, artificial intelligence, to see the tissue thickness. You can see I'm able to sit in the console away from the patient, insert my stapler then. So the minute the staple goes across the bowel, and closes, there are 1,000 measurements per second, which is being sent to the central computer. I have a pedal which I have controlled, then I'm firing, and all this is done in a very smooth. Now you can see the yellow line going, the smooth fire across, and you can see how beautifully it is done. That's how technology has changed our life. There is no pushing, pulling, because this staple line is very important when we want to achieve a good staple line and a good anastomosis, so that complications like anastomotic leaks are rare. So we are already using AI in surgery for achieving this for rectal resections. So you can see that our time taken for the first 150 cases in our program is come down compared to the second 150 cases. Looking at our outcomes, our cancer margins are much better compared to the global standard. Our nodal harvest rates are better. Our own leak rates are less than 1% compared to 2.6%, which is the global standard. Published data from the US and the UK. Our wound infection rates are 1/5 of that what is published in the global standard reports. Our readmission rates are almost 1 out of 2% compared to 20% in the US. Our conversion rates when you do a laparoscopic operation for rectal cancer, the conversion rates are 15%. In robotics, it's 7%. In our center, it is less than 1%. Because of our subspecialization, standardization, we're able to achieve all these results. Now, the cost of robotic surgery itself, if you look at, because of all these small, we use less instruments, subspecializations, standardization, operation, cost efficiency in theater and workflow, our cost has been brought down to almost 1/5 or 1/6 of what's in the US. Or, our average cost for our general ward for robotic cancer is about between $5,000 and $6,000 for a Indian patient. So we are able to get the cost really down to that level because of all the reasons I've explained to you. Now, we launched the Apollo Rectal Cancer Program, the ARC program, which is the only quaternary care center program for rectal cancer in India. It is one of the highest volume rectal cancer centers in the subcontinent. We use advanced technologies such as chemoradiotherapy, proton therapy, and robotics to achieve our vision. We have single surgeon, which we mean, colorectal single specialty for a single operation. Essentially, we are surgeons who do primarily only colorectal surgery or primarily rectal cancer operations in our unit. So if you look at what we've done, once we started the subspecialist program, our volumes have steadily increased. Our robotic volumes have also increased across all the specialties because it has a halo effect of all the patients, more patients being referred for robotic programs. So we also do an international symposium where we encourage our collaborators from around the world to come along and talk to us, learn from us. This happens almost every 2 years now. We've completed 5 programs so far, and I encourage people from Kenya to come and join our annual program. The next one is going to be in March 2026. We also do a lot of awareness and education in the community. It's very important because once the community is educated, they will seek help earlier. And we also educate the public so that they will go and tell their families, their businesses, their staff to seek help or create awareness in colorectal symptoms. It's been a long journey, but it's important that we can start and within 10 years, we can build a very wonderful colorectal program with achieving the best outcomes in the world. So how can we collaborate and upskill teams? We have a ARC 360 program where we teach and train people in MDT, robotic surgery. We have national and international faculty. We encourage people from Kenya to apply for these 360 meetings. You will have an insight of what is going, how to set up programs, how to train, and to learn from the experts and how to work as a team. We have several fellowships which we have people who come from around the world to learn from us. We also are doing a telesurgery, working on a telesurgery project where we'll be able to operate from Apollo Chennai to remote locations, hopefully someday even in Africa, or support your robotic program there in Kenya with some difficult cases. And so thank you for hearing me out, and I'm looking forward to collaborate and upskill surgeons from Sub-Saharan Africa. Thank you.
Okay, thank you so much for that. It was quite informative. And guys, for all of us, follow us in the webinar. Kindly continue putting through your questions for Dr. Venkatesh, so that after Dr. Bala, we can have a Q&A session and he can be able to answer all your questions. Already I've seen a few started coming in. Maybe before Dr. Bala comes in, maybe I can just have one question for Dr. Venkatesh, and then we can continue with Dr. Bala.
Sure, go ahead.
Okay. So this question, can untreated H. pylori be a predisposition to colorectal cancer?
H. pylori primarily causes chronic gastritis, and it's a precursor for chronic gastritis, in turn is a precursor for stomach cancer. There is no direct correlation with colorectal.
Okay. One last one.
I also seen that married people 2.5 times to be diagnosed. So apparently that was interesting, and I found that research based on that married people tend to drink together, and they tend to have a higher risk of colorectal cancer. Very interesting though. So that's what I found. Yeah.
Yeah. By drinking together, you mean alcohol or?
Yeah.
Okay, cool.
Drink water. You're not going to get that.
just a clarification. Okay, so are patients with conditions or disorders such as IBS or SIBO at a risk of colorectal cancer?
IBS?
Yeah.
IBS and SIBO not particularly, but if your high fiber diet is very good for digestion, and it has a good bacterial growth, and if your diet is not good, they can has been indirectly suggested smoking, alcohol, high red meat intake. These are the conditions which are being directly linked.
What about gluten?
Gluten foods, not particularly of my knowledge.
Okay, cool. I guess we'll go over to Dr. Bala Murugan. Welcome. He can have his presentation, and then we can have our final Q&A. Thank you so much, Dr. Venkatesh.
Hello. Am I audible right now?
Yes, you are.
See, yeah. Okay. So, I'm Dr. Bala Murugan. I'm a surgical gastroenterologist and robotic surgeon in Apollo Proton Cancer Center. And I'm more focused on the upper GI and hepatopancreatobiliary division. So myself with my lead, Dr. Venki Munikrishnan, he takes care of the colorectal unit, and myself with Dr. Sudipta, we take care of upper GI and HPV. So, upper GI, so this is our center, Apollo Proton Cancer Center, where we have a proton radiation therapy with the robotic surgery. We do a high end of cancer work here with world-class results. So coming on to upper GI cancers, what is upper GI cancer? Upper GI cancer are those which affect these following organs: the esophagus, which is the food pipe, and the stomach, and we have a liver and the pancreas and the gallbladder. So, so yearly detection definitely saves a lot of life, because this upper GI cancer, especially the esophagus and stomach, can be easily found out using during endoscopy, and liver, of course, can be done easily with the ultrasound, normal ultrasound scan, which we do in our OPD basis, can definitely will diagnose the liver cancers. So coming on to the statistics in Kenya regarding these cancers, the esophageal cancer, the gastric cancer, and the liver, each year there are about like 2,500 plus esophageal cancers and 1,800 plus gastric cancers, and the liver is 3,000 plus. So why there is an increase in these esophageal and liver cancer? When you go on to it, and when we take the statistics in the Kenya, the top risk factors that are contributing to the esophageal cancers is the hot tea, the ingestion of the hot tea, and khat. Khat is a type of tobacco or something which is being used, and that increases the risk of the esophageal cancer, especially in Kenyan population. And gastric cancer, of course, because of the H. pylori infection and the smoked food. And liver cancer is getting high because of the increased hepatitis B infection and aflatoxins. Aflatoxins is nothing but this is a fungal infection on the maize and some food material that affects the liver and causes the liver cancer. So this is the statistics in relation to the Kenya, which in relation to the upper gastrointestinal tract. So what is an esophageal cancer? Esophageal cancer, it's a food type that connects the mouth that connects the throat to the stomach. So it's a tube. So getting the cancer in this area definitely is deleterious, because the food intake is less, and these are all aggressive type of tumors. These esophageal tumors, gastric tumors, pancreatic cancers, and liver, they are somewhat an aggressive type. So when we detect very early, definitely there is a high possibility of cure for these patients. But unfortunately, they are presenting at a very later stage. So they present with a lot of metastasis, the spread of the tumor to somewhere else in the liver, brain. So in that time, curing the cancer makes us very difficult. So the symptoms and risk factors for these esophageal cancers. What is the symptoms you get through this esophageal cancer? Is the dysphagia. Dysphagia is nothing but difficulty in swallowing, and pain during swallowing, and heartburns. These are all some of the symptoms of the esophageal cancers, and weight loss. So what are all the risk factors? The smoking, alcohol, hot beverages, as I said, the hot tea, and Barrett's esophagus. So Barrett's esophagus is a condition. It happens in the esophagus because of the chronic exposure of the stomach acid to the esophagus. Because esophagus is not intended to be harboring this stomach acid, but because of hiatus hernia or acid reflux, they have been constantly in exposure to this acid, making esophagus vulnerable for cancer. So, and then comes the stomach cancer. Stomach cancer, everybody knows, stomach cancer is a storage organ in the abdomen, which produces the cancer usually presents with the symptoms of indigestion, bloating, anemia, and blood vomiting. So the risk factor for this stomach cancer is the most common when prevalent in this Kenyan population is the H. pylori infection. H. pylori is a bacteria that affects the stomach mucosa, causes the constant irritation to the stomach mucosa, and makes the patient vulnerable for this stomach cancer. And smoked food or the fried food, and family history. Coming on to the liver and pancreatic cancer. So it's a complex anatomy. You could see the liver, pancreas, and the gallbladder, they are all mingled together in a complex anatomy. So whenever there is a cancer in these areas, they produce symptoms like jaundice, abdomen pain, and unexplained weight loss. So the risk factors for this liver cancer is the chronic hepatitis B infection, hepatitis C infection. These two are the infections that are transmitted through blood transfusion or through sexual sanitary transmission. And these infections definitely in a long run, they produce the liver cancers, especially the hepatitis B. Then you have aflatoxins. It is more common in Kenyan population because of maize storage, and which got affected with this fungus. And of course, the alcohol ingestion they produces the lot of liver cancers. So when to see a doctor for this liver cancers, or when to see the doctor for these upper GI cancers? We have a red flag signs. We have a red flag signs. When you have a persistent symptoms like more than 2 to 3 weeks in the family history of upper GI cancers and unintentional weight loss and chronic acid exposure or the indigestion or the bleeding, definitely these are all the red flag signs which you need to check, because there is a myth that indigestion is a normal thing and it is only temporary, it will go on its own, but definitely not. Indigestion for quite a long period, definitely it produces a constant irritation to the stomach wall and landing up into the stomach cancers. So these signs should not be overlooked. Definitely you need to see a doctor whenever you have symptoms like this. So what are all the screening and or the diagnosing techniques for this stomach cancer? It's a simple office procedure called endoscopy. Endoscopy is nothing but a small tube that has been introduced through the mouth. It goes through the esophagus and reaches the stomach, and there you could see the stomach mucosa. You can see the mucus of the stomach mucosa, duodenal mucosa, esophageal mucosa. Whenever there is small changes, whenever there is a small earlier changes of cancer, it can be easily picked up. This yearly screening, which made the Korean countries and the Japanese to overcome the stomach cancer, because they diagnose at a very early stage, like in whenever this cancer is being changing in a cell stage, they diagnose it very early, and they can easily treat with endoscopy or with a small gastrectomy, because they don't need to go for a radical gastrectomy, because they find these malignancy at a very early stage. So with this we can find out the lesions. So this helps us to find out the esophageal and stomach cancer. And of course, for other purposes, what are all the investigations you need to do for these cancers? We need to take a biopsy for that, and after that we need to see for the CT scan, MRI and PET scan. This helps us to stage the disease. And of course, you have tumor markers for the liver, you have alpha fetoprotein, and for the pancreas you have CA99. These tumor markers will guide us, like if the treatment is going in a good direction or not. So these are all the investigation we do for the upper GI cancers, and we have to look into the stages. So any cancer, whenever you find out the staging of the cancer. So usually, depending upon the growth of the tumor, we stage the disease. So stage 0 when it is very, very early, and stage 1 when it is only into the inner layer of the stomach, and stage 2 when it is reaching the muscle layer of the stomach, and stage 3 when it is reaching the outside of the stomach, and stage 4 when it goes to all other structures. So this staging definitely can be made out with these investigations like CT, MRI and PET scan and endoscopic ultrasound. They help us to guide us which stage the tumor belongs to. So what are the treatment options we have for this upper GI cancers? As for the any cancer, the treatment option is, we have 4 treatment options. One is the main surgery is the mainstay of treatment, and then comes the radiation therapy, chemotherapy, and the targeted therapy, which is the immunotherapy. Of course, you cannot avoid this nutrition and supportive care, which helps to manage the side effects of these treatments. So surgery, of course, surgery is we call it as surgery, as open surgery, laparoscopy, and right now we are more on to the robotics. So these surgeries, this is an evaluation. In the same evaluation, radiation happened before. We have cobalt radiation, and now we have moved out to the proton radiation. In the same way, chemotherapy has gone through so much of evolution. The same way, targeted therapy, we check each and every genes in the cancer, and towards the gene we target these genes with the immunotherapy. So what is the burden of upper GI cancer in the Kenya? Why this matters? Because upper GI cancers are the leading cause of cancer death in Kenya, often diagnosed late because of the limited screening. So among this, we divide this upper GI into luminal and extraluminal. Luminal cancer, among luminal cancer, the esophageal cancer is the most common upper GI cancer, and many of the cancers are diagnosed late, and because of that, the survival is very low. So how to prevent this? Create awareness among the population and make them yearly screening. These are all very crucial for us to create the awareness and yearly screening so that this cancer can be diagnosed at a very early stage so we can be treated. So the 5-year survival rate, you know what happens in Kenya, the 5-year survival rate for all this cancer is less than 20%. But in high income countries, even though even though on the latest stage also the treatment, because of the better treatment, the 5-year survival rate is more than 50%. It's from the source of Globacon 2022. This is the study. So what are the challenges in the Kenya? So because the challenges here are limited screening programs, so we need to increase the upper GI cancer screening with endoscopy units, which are scarce outside the major cities, and ultrasound screening for the liver and the pancreatic CA. And you have to create more awareness among the population regarding the high risk exposures. For example, H. pylori infection, smoking, alcohol, and aflatoxin contaminated food. These are all the exposure you need to talk about. And the other challenge is the high cost of biomarkers tests, especially CEA, CA99 are available in only some of the private labs. These have to be tied over to. And there are cultural barriers in Kenya that also it's a barrier for the treatment. Like the symptoms like heartburn and weight loss are often ignored and attributed to some of the stress the patient is going through. And there is also cultural stigmata. Cancer is equal to death sentence. But we need to create awareness among the population to tell them that cancer is never a death. We can definitely win the tumors. So who are all at the high risk of developing cancers? Definitely the patients with chronic H. pylori infections. This is the bacterial infection that infects the stomach and causes stomach cancer and lymphoma of the stomach, and aflatoxin, which affects the maize and the food material that causes the liver cancer. And you have chronic hepatitis B carriers, they develop into liver cancer. And esophageal cancer is more on the West Kenya because of the hot spots. They have a hot tea consumption, tobacco, and poor diet. So this causes the increase in the esophageal cancer. So early detection, definitely it overcomes the barriers in the Kenya. So screening gaps is there because we have less than 10 endoscopic units outside Nairobi and Mombasa. And then the H. pylori prevalence among the Kenyan population is 80%. This 80% is being studied by this Kenyan Journal of Gastroenterology in 2021. But what is the solution for this? We can provide a mobile endoscopic vans. This has been done in countries like Korea and Japan long back because they have a very high incidence of stomach cancer. They have a mobile endoscopic units. It's a pilot program that's happening in Mombasa and Nakuru, where you can diagnose easily the stomach and the esophageal cancer. And definitely there are other tests, low-cost tests to diagnose the H. pylori infection. These are all stool antigen tests for the H. pylori that when it is becoming positive, we can treat the H. pylori infection by simple antibiotic, which prevents the stomach cancer and the stomach lymphoma. Of course, for those who are the chronic hepatitis B virus or C virus patients, definitely the liver ultrasound and alpha-fetoprotein blood test definitely helps us to completely screen the liver. And definitely we can build a jaundice clinic. So most of the jaundice, the problem is most of the jaundice patients, they go in for native treatment. It's been the same in India as well. This native treatment definitely delays us the diagnosis of the cancer because during the native treatment, most of the jaundice will be because of the hepatitis A. So these hepatitis A cancers, definitely this hepatitis A cancer, hepatitis A infection, they will come and go off like a common cold. But 10% of the jaundice definitely are attributed to malignancy that are being stuck into this hepatitis A group. So definitely jaundice clinic we need to make, and it will help us to look for the pancreatic cancer and the bile duct cancer. So patient education is also very important because culturally sensitive messaging has to be sent to the patient regarding this red flag signs like persistent stomach pain, unexplained weight loss, jaundice and bleeding, be it blood in the stools or blood in the vomitus, whatever. We need to teach the patients regarding these red flag symptoms. So these symptoms should never be overlooked, should never be thought like a stress, should never be thought it's just a simple piles. Definitely has to be checked with the gastroenterologist or any physician to rule out the yearly malignancies. There is a myth because mirror, it's a cut. It thought that it helps us to cure the stomach pain, but it increases the esophageal cancer. So this sensitive messaging should also be said to the patients. So the advanced treatment. So what are the advanced treatment that are available for these cancers? The advanced treatment is bridging the gap for the Kenyan patients. These are all the advanced treatments that are available for the cancer right now. The minimally invasive robotic surgery, proton therapy for upper GI cancers, especially for the esophageal cancer, pancreatic and liver cancer are not amenable for the surgery, and precision medicine and targeting therapies. Because, for example, if the patient is diagnosed to have a gastric cancer, we test with the head-to-new gene. The head-to-new gene, if it is testing positive, because 20% of the stomach cancer harbor this gene of head-to, and this 20% will be benefiting from the immunotherapy called trastuzumab. In the similar way, if the MSI testing is high in the patient, these may benefit from the pembrolizumab. So these are all the advanced treatments like minimally invasive robotic surgeries, proton therapy, and the targeted therapy, which helps the patients to completely win the cancer. So the coordination is we need to have if there is a collaboration with the Kenyan doctors, we can definitely have a virtual MDT. It is the multidisciplinary team, which will we can make it weekly virtual consults with the MDT, where we have a surgical oncologist, pathologist, radiation oncologist, radiologist, medical oncologist, nuclear medicine specialist, and medical gastroenterologist. All of us sit together or connect through cloud. We can connect through internet. We can talk to the each and every cases. We can discuss and we can tailor the treatment. So this is the multidisciplinary team. We can make a virtual consult with the Kenyan doctors so that we can each and every cancer cases we can discuss in detail and tailor the best option of the treatment. So we need to have a digital integration. We need to have a telemedicine, and further, when this collaboration goes well, we can even plan a tele-robotic surgery as said by Dr. Venki. And we need to talk about this tele and endoscopic consultation as well. And mobile health financing units can help the patient to mobilize to India as well. So definitely not the treatment of the cancer doesn't stop with this. We need to have a post-treatment supportive groups, because I could see only 3 palliative care centers. They offer pain-free management in and around in Kenya. So we need to increase the palliative care as well, because once the cancer has been diagnosed and once it is thought like it has metastasis or it has gone outside, it doesn't mean the treatment should be stopped. We can have a good quality of life for the patient with pain-free, symptom-free life, and we can even increase them with the immunotherapy their lifespan. So as Dr. Venki has told, the recent advances in the surgery for GI cancer it has moved from like how the human has evolved. The change is nothing is the only constant. Everything is changes. So we started with the open surgery, and then we went into the laparoscopic surgery, and now we have moved on to the robotic surgery. Myself being a upper GI robotic cancer surgeon, we do mainly upper GI cancers, especially esophageal cancer, pancreatic cancer, and the liver cancer and stomach cancer. What is the advantage of this robotic cancer surgery, especially when the esophagus is concerned? Because as Dr. Venki said, there are a lot of nerves that are supplying the sexual function. The similar way for the esophageal cancer, lot of nerves that are supplying the voice box, no, they have been attached with the esophagus. When the surgery is being done for them, the lymph nodes, the lymph nodes or the draining lymph nodes from the esophagus, they had to be removed. But these lymph nodes are being attached to these critical nerves that are helpful for the voice. So these nerves can be easily removed with the robotic surgery than any other means, because this robotic surgery helps us to preserve these nerves, and so the patient function is better out after surgery, as well as the patient's voice can be preserved. So in this way, the robotic surgery definitely helps for the esophageal cancer. Similarly, for the pancreatic cancer, the reconstruction, when you do a surgery for the pancreatic cancer, you have to remove a part of the pancreas, a part of the bile duct, a part of the stomach, and the small intestine. But the reconstruction, so that when you do a reconstruction, you have to join the pancreas with the rest of those bowel. When you are joining with the robotic, it is very precise because of the 3D magnification, as well as it is similar to like how we do a open surgery, so in a keyhole manner. So that is how post robotic pancreatic surgery patient recovers well. So these are all the benefits for the patient: shorter hospital stay, reduced blood loss, and smaller incisions, and faster recovery, and reduced pain and scarring. There are also a lot of benefit for the surgeons also for the robotic surgery, because it improvises the visualization, which indirectly helps the patients to recover. It produces a wider range of movements so that more complex procedures can be done. It reduces the fatigueness of the surgeon. In the way, it increases the effectiveness of the surgery, and with a greater precision, we can do it, and training opportunities. Because while you do a robotic surgery, there are fellow surgeons or the junior surgeons or the students. They stand behind you. They look into each and every structures what you have been doing. In this way, it gives us the opportunity to teach the younger generation so that they come with the better robotic surgery skills. So this is the core technology for the robotic surgery. You have magnified 3D vision and endorsed intuitive motion and enhanced ergonomics. So these are the components of the Da Vinci Xi, which is the 4th generation system we have in India. And it has 3 components. You have a patient cot and a robotic arm and a console. So console is where, this is the console, it is where the surgeon sits and operate. And this is the patient cart, through which the ports are introduced to the patients and they operate. And this is the vision cart, through which the assistant surgeon, he will be sitting by the side of the patient to help the surgeons. So it's a small video how we dock the patients, because everybody has a doubt like how this robotic surgery does. So it is a small video you could see. This is the patient cart. That is being the column is being elevated and it is moved towards the patient, and it rotates, and each and every arms is connected to an instrument, so it aligned together once the instrument is activated, and the patient card is moved towards the patient. So it's a sample video which showed how the ports are made and how the arms are collected and how the instrument are inserted. The first inserted one is the camera port, camera, and which helps us to align. So now the rest of the arms is aligned together, and now you could see each and every instruments are attached to the arms. So this is a left hand working port. Under vision, the instruments are inserted. And the right hand is inserted. So then after this, once it is done, now the surgeon sits on the console, as I showed before. The surgeon sits on the console and he started working. So this initial step is called docking. It is done initially once the surgery is started. So in future, we have a lot of hopes because you could see there are multiple ports being placed on the abdomen, and future there is no doubt, yeah, you can have a single port through which the multiple arms are attached, and you can do surgeries through the single hole. So when you look closely into the camera, when you look closely into the camera, I mean it has the light and the camera. So just like an insect, it can go inside, and we can do wonders. So this is a sample video of how this robotic surgery, especially for the esophagus, stomach, and liver, it helps us to the enhanced surgery. So you could see this is a robotic view, and this is a vessel. This vessel is actually 3 millimeter. It is actually 3 millimeter, while 3 or 4 millimeter. But when you look into the magnification, it looks as if like a 5 centimeter. So this is how inside the console you look into it. So when you see how precisely and how slowly the action is being done. So such a blood vessel you can manipulate slowly and then dissect. So now the entire vessel is being dissected, and with robotic clips it is being clipped and it is being cut. So this is how robotics works. So this is a small sample video to help to understand like how magnified the robotic system is. So these are all this is the collaboration of myself with the Kenyan patients, because this patient had a robotic stomach cancer surgery. In grateful for his recovery. This picture is post surgery, is almost like after a week after surgery he got discharged. He's very grateful, and he gave me the collaborated picture, collaborated book and cup. It shows both the countries. Flag has been imprinted, and my name is. I'm so moved with this, and there are a lot of other patients. After getting the patient consent, I posted his picture and lot more. So this is how we can collaborate and we can do wonders further. So how to reduce your cancer risk? Definitely, you need to quit smoking and quit alcohol, and you have to stick on to the healthy diet, and you need to have a very good physical activity, and avoid exposure to too much of sun, especially for the Western countries. And you need to reduce the air pollution, control your weight, and definitely this is more important, vaccinate against hepatitis B, because this vaccination definitely reduces the risk of the hepatitis B transmission. In this way, it definitely helps us to completely come out of the liver cancer. And do not forget to participate in any cancer screening programs. So take charge of your health. Cancer is treatable if detected early, and listen to your body and seek the medical advice if the symptoms persist, and spread awareness among the family and friends. And let's work together to fight cancer in Kenya. Thank you.
Okay, thank you so much, Dr. Morgan. I guess now we'll just enter into our Q&A session. It was very informative. I think Dr. Morgan, you just have the pleasure of answering all of our questions. So yeah, I guess we'll start with more light questions on genetics. So is cancer hereditary, and how does family history impact a person's risk of getting cancer?
Definitely.
Okay, yeah, go ahead.
Yeah. Go ahead. I'll just.
Okay. So
cancer, not all cancers are hereditary, but definitely in 10 to 20% of the cancers are hereditary. For example, if the patient is getting any cancer at the younger age, for example, if the patient is getting colorectal cancer at the age of less than 50, definitely the risk for the next generation to get the colorectal cancer is higher. So when you get a cancer at a younger age, definitely the risk of genetics is more, because in a stomach cancer it is concerned the 20% of the population, the HER2 gene is transmitted, and that causes the cancer. The same way in the breast cancer, we have BRCA1 mutation and BRCA2 mutation. These two, BRCA1 and BRCA2, they are transmitted, and definitely they have a high risk of breast cancer, uterine cancer, and endometrial cancer. And when for the colorectal, we have HNPCC, we call it as hereditary non-polyposis colorectal cancer syndrome. These patients have a higher risk of developing the colon cancer. And you have a condition called FAP, familial adenomatosis polyposis. This patient have a 100% risk of developing colon cancer. So whenever you find this FAP patient, we'll definitely recommend a complete removal of the colon, so that they future, definitely, the Angelina Jolie has removed both her breast because she's at risk of developing cancer. Before she developed any cancer, she tested a gene and found to have a BRCA mutation, and she removed the breast. So that is how we have to move towards, to completely win the cancer.
Okay, thank you so much for that. I'll go into diagnosis. So will you kindly reiterate to us the importance of constant screening and early diagnosis in GI and colorectal cancer?
Definitely, early detection, definitely, we can completely cure the cancer, because see, as I showed, the stomach cancer, you have a inner layer, middle muscular layer, and an outer layer. When the cancer is in the inner layer, when you diagnose it with endoscopy, definitely with endoscopy itself, you can remove a part of that inner layer, and the patient is out of cancer. The similar way, when you find the patient with the muscle layer alone, when there is no lymph nodes involvement, then definitely you just remove that part of the stomach. The patient is out of the cancer. So in this way, early diagnosis definitely helps, because once the cancer has moved to the lymph nodes, or moved out of the stomach, or out of any other organ which is being attached with, definitely the risk of curing is less. When the lymph node spread is more, we can the cure rate is getting reduced. So definitely, that is why early detection definitely saves a lot of lives.
Okay, just a few more questions and then we are done. So what are the most promising advancements of AI and biomarker-based early detection for stomach and digestive cancers?
So more AA mediated is as I said, for the stomach cancer in endoscopy, you can find out the early lesions. But when you don't find any lesions in the stomach, you can use AA technology in the endoscopy itself. So it will see only when the lesion is 1 centimeter or 2 centimeter in the endoscopy, it will tell us if there is cancer is there or not. But during using AI technology, we can go deeper into it. You can look at the microscopic level when there is only some clones of cancer cells are there. So in that case, you can diagnose much more earlier, not even when it reaches 1 centimeter. You can diagnose at the very early stage of just a transmission. Then you can, because this AA mediated, it will throws up our light. It shows the microscopic view, and it helps us to diagnose the cancers at a very early stage, even less than 1.5 centimeter.
Okay, thank you so much for that. Just two more and then we wrap up the session. What are some of the risk factors of pancreatic cancer, and why does it take so long to diagnose?
Yeah, because the pancreas is an organ that is deeply seated into the body, because it is not into the surface. Okay, so since it is deeply inside, and most of the time, the cancer, it has to increase to such an extent to cause compression on the bile duct. If it is not compressing the bile duct, there won't be any jaundice for the patient. So till it is increasing in size to compress the bile duct, the cancer continues to grow. So only when it is compressing the bile duct, the patient will develop jaundice. Then he will investigate to know whether he is having pancreatic cancer or not. So that is the reason why most of these patients, they come at a later stage. For example, it reaches 4 centimeter, 5 centimeter. Only then it will develop the jaundice. So till the jaundice is not there, the patient thinks he is normal and will be roaming, but he'll be harboring. So the 1 centimeter, 2 centimeter tumor detection is the crux, and that makes the difference in the patient's life. So, and one more thing, what are all the risk factors? The risk factors for the pancreatic cancer is alcohol ingestion, because it produces chronic pancreatitis. Any chronic irritation to the pancreas definitely makes the patient to develop into the pancreatic cancer. And next is smoking, and of course now, and this is more pertaining to the low socioeconomic status people, where they eat a lot of this cassava food, which increases the chronic pancreatitis and which makes them more prone for the pancreatic cancer. So these are all the risk factors, and these are all the reasons why the pancreatic cancer always presents late.
Okay, thank you so much for that. So would you kindly tell us how long treatment takes for cancer, especially GI and colorectal cancer, using different modalities such as proton therapy, chemo, radio?
Yeah, understand. See, for example, the patient is having a colorectal cancer. So we stage the disease. Okay. So once the patient is diagnosed to have colorectal cancer, we stage the disease. If the patient is having very early stage, when there is no lymph nodes are involved, only the muscle, only the inner mucosa is involved, a direct surgery, robotic surgery itself is sufficient. So once a patient is diagnosed to have that cancer, you operate. Patient will be ready after 5 days after the surgery. Then we look on to the pathology report. We will come to know whether the lymph nodes is involved or not. When there is no lymph node involvement, when there is no muscle layer involvement, that's it. That is the end of the disease for him. So no other treatment is necessary. But when the rectal cancer, when you diagnose the patient with the rectal cancer, and if there is a muscle layer involvement, or if there is a lymph nodes involvement, then the patient has to go for a long course chemotherapy with the radiation. So this is called as a long course NACT. It goes for around like 1.5 months, and then you have to wait for another 1.5 months, and then we operate for 5 operate, and recovery will be there for another 5 to 6 days. So 1.5 months, 3 months, 3 months plus 5 days, and then looking at the biopsy. If the biopsy is complete, patient is usually after chemo and radiation, sometimes the tumor will disappear. So when you operate and look into the pathology report, there won't be any tumor. In that case, it is a good prognostic factor. So most of these patients need not do any other post-surgical chemotherapy. Just after surgery, that is enough. But if a post-surgery also in the histopathology, you found any tumor cells still there, then you have to go at chemotherapy for another 6 cycles. So totally it will be like 4 to 5 months, the entire duration for the rectal cancer. And for the esophageal cancer also, this is the same. So it will take like 4 to 5 months. For the pancreatic cancer, similarly, if it is very early it's all same. Like when you find a disease at a very early stage, you operate, the patient will be discharged in 1 week, and that's after that there wouldn't be any problem. But only when the patient is presenting to us in a later stage, there comes the difficulty. So you need to give chemotherapy, radiation. This takes for 1.5 months to 3 months, and you operate. And post surgery also, if you need any chemotherapy, you have to look into the biopsy report. That goes for another 3 months. So totally it comes to 6 months.
Final question. So I'd like you to take us through some of the things that we can do in managing some conditions that we have, such as gastritis, acid reflux, and some of the things we can do in terms of diet and lifestyle so that we
Yeah.
can manage stomach and
Yeah,
digestive.
it's a good question, because in my OPD, most of the patients will come with this gastritis and acid reflux. So gastritis definitely because of H. pylori infection. When this H. pylori infection can be treated with antibiotics. If not, definitely you can increase the probiotic intake. Probiotic in the sense you increase a lot of probiotic food, for example, curd. You can increase yogurt, and these food definitely will increase the probiotic, I mean the human friendly bacteria in the stomach wall, and it combats with the H. pylori bacteria and it kills it. So in this way you can combat this H. pylori. So these are all some of the tips for the tips in the home remedies to tide over this gastritis. And for the acid reflux, you have the treatment for the acid reflux is first lifestyle modification. You need to stop drinking coffee, stop drinking tea, and you have to eat 6 meals a day, which means you need to eat a small meals multiple times. So when you eat a small meals multiple times, it won't reach up to the esophagus. When you skip a meal and you are hungry and you jump into the food and eat a stomach full meal, then there comes the problem. You get acid reflux. So you have to divide your meal into 6 times per day, and you should not lie down immediately after eating a meal. So if you take a good meal and you feel sleepy and you lie down immediately, definitely the food goes into the esophagus and stays there. So there comes the problem. It creates a bad environment there, resulting you to get the acid reflux. So these are all the lifestyle modification. And in my country, what we do is we cook rice in the night and we keep it with the water overnight to make it get fermented. And next day morning we drink that fermented rice water. So that helps us to prevent the acid reflux as well. And we have even published this with good results. So these are all some of the lifestyle modification to get over this gastritis. And recently what happened is, previously like 10 or 20 years back, we don't go outside often and eat. We have a single kitchen food. But what happened right now is, every day we order a food, it comes to the home, and we eat a different hotels food in a way in the home. Because of that, the home ecosystem is being affected. So a lot of bacteria comes in, lot of bacteria fights in, and a bad bacteria often wins and create gastritis.
Thank you so much, Doctor.
Thank you.
For all your insights, and kindly allow us, if we haven't answered your questions, we will be sending you direct emails to everything that you will be asking. So I want to thank Dr. Balamurgan and Dr. Venkatesh for coming through for this session. I'm sure we have learned a lot. The questions came in very hot, and we are short of time, so we had very little time to answer everything. But I am hoping that whatever we've put through to the doctors has been answered in some way or another. I've tried to generalize some questions as much as I could. So for those of us wondering how you can get to either Dr. Venkatesh and Dr. Balamurgan, we have a email address and a phone number that will be linked into this session soon through the marketing team, and all of us will get the recording via email, as well as any extra questions that we may have to our doctors. Feel free to get your inquiries in, whether you're a patient, whether you are a referral partner or an insurance partner. I'm sure that both doctors will be more than happy to answer your questions, do consultations, or anything like that. So without further ado, I would ask Eva to just do a quick final vote of thanks, and then we can end the session.
Thank you.
Thank you, Doctor. Thank you so much, Dr. Bala. Thank you.
Okay, so thank you so much, Chebe, and thank you to the two doctors that have taken us through today's session. And for the rest of the team for taking part in the session and for all the questions that you've sent through. I'm hoping that it was also very informative for the rest of us. So as Chebe mentioned, we're going to send the recording for today's session to your emails. And not only that, we're also going to send the answers to some of the questions that were not responded to. And finally, we're going to send a link for how you can reach out to us in case you have any questions, or if you want to make an inquiry to Apollo, we are free to connect you to the doctors. Asante sana and have a good afternoon.